Good evening, dear friends and colleagues. I would like to thank you all, first of all, definitely, because in this critical situation you've attended. This is a very critical period we are passing through, especially in our country. I'm talking about the pandemic that made our life so difficult and even hard, especially in our medical career. I can say that in all our years involved in healthcare, this is the most massive medical mystery we have encountered. The way patients are triaged, diagnosed, treated, and monitored will forever change, I think, because of COVID-19. And I think this is more evidently seen in cardiology field than in any other field of medicine. This is why tonight we are virtually meeting. It's a pity we are not physically bonded or found. Tonight we will definitely talk about a very special and a very likely topic to interventionists, which is a complex bifurcation, stenting of the left main and bifurcation techniques. This is sponsored by Medtronic, whom we really admire and thanks a lot for their contribution. We are also honored to have with us Professor Goran Stankovic, who is an eminent speaker and who is more than famous to be introduced. I will not definitely introduce him because he's already known for all of us for his career. And a special thank will be also proceeded for Professor Ziad Ghazzal, for Gilbert Abi Nader, and for Ali Sayed, our friends, for their efforts to make this event come true. And I hope it will be a successful event tonight, hopefully. We are definitely also proud to have you all among us in the Lebanese Society of Cardiology. I will definitely start by Professor Dr. Ali Sayed talking about his first case presentation about bifurcation technique stenting. And we will have definitely an interactive session. Questions will be sent into the chat box, and we will have definitely to be answering these questions from Dr. Ghazal, Dr. Goran, and definitely any comment is well taken from the speakers. Thank you. Ali, you can start, please.
Thank you, all of us. Thank you, Dr. Malek. Thank you for this opportunity to having.
You need to speak closer to the microphone so that we can hear you better, Ali, please.
Thank you, Dr. Malek. Thank you, all of us. Thank you, Dr. Ghazal. Thank you, Dr. Goran. I will present a case of left main stenting. This is a 70-year-old female patient known to have coronary artery disease with the previous stenting of the RCA with 2 DES 1 year ago, and stenting of the LAD with 2 DES, and stenting for the circumference with 1 DES. Hypertension on triple therapy. Their medication is aspirin, clopidogrel, ACE inhibitor, beta blocker, diuretic, and statin. Patient present for chest pain on minimal exertion. Transthoracic echo done, normal EF with grade 1 diastolic dysfunction. Her EKG, nothing much on the EKG. And we ask her to do a cardiac cath. This is the right coronary artery with a patent stent on the proximal and on the mid RCA, with a 50% on the mid RCA between the two stents. There is a lesion on the left main. We'll see it in the later. We have a patent stent of the LAD with a 50% on the mid LAD intrastent. We have, if we see here, there is a lesion on the ostial of the circumflex and most likely on the proximal LAD. And in this incidence, we see there definitely a lesion on the left main, taking the ostium of the LAD and the ostium of the circumflex.
Okay, so Ali, do you have more to show, or shall we maybe perhaps?
Yeah, this is the final incidence. No, this is the final one for the cardiac catheterization.
Yeah. So, but and then you have stents. I think in the almost in the ostium of the LAD, proximal to ostium LAD, and in the circumflex, correct?
Yeah. Yeah.
Okay.
The proximal LAD, proximal circ, and mid LAD.
And this looks like a 1-1-1 type of
yeah
lesion. Yeah. So let's throw it around a little bit as to what are the different approaches here. Maybe Dr. Goran, if we start thinking about, let's review quickly provisional stenting, for example. Knowing that most of the time when we tackle bifurcations, we have to try to keep it simple and safe. And at the same time, here we're dealing with the left main. It's very complex. We have a 1-1-1. All lesions seem to be tight. So can you discuss with us, would you look at this and say it's going to be a two-stent technique from the beginning, or would you say it would be a provisional type of stenting technique?
Yeah, thank you very much, Professor Ghazzal. First of all, thank you very much for the kind invitation. We were planning this meeting live for the last January. Yes. We were unlucky because of political issues in that period. I really wanted to come. I love Beirut very much. I think it's something that I will miss in case this lasts longer. I hope we need to plan something in the future to organize again with PCR real webinar live with attending physicians from the region in physical contact, that you can look at their eyes, you can understand who is interested in what, who would like to ask questions. This pandemic really changed the way we share the knowledge between each other. But at the same time, I think it's very important to use maximally these virtual digital platforms to keep pace and not to miss a year waiting for situation to normalize. I'm happy I was vaccinated last week on January 5th. So I have another vaccination in 21 days.
And which one did, oh, so it's Pfizer since it's 21.
It's Pfizer, yeah, because that was the only one, the first one that came was Pfizer. And of course, as someone who people know here, I was the first day among volunteers to get vaccine. And I'm so happy I shared it on my Twitter immediately as soon as I got it. I think for future normal meetings, it's very important to take vaccination and then make this again kind of normalcy. Regarding this case, first of all, when you say provisional, I think most of colleagues know that I'm a member, board member, and now the current president of the European Bifurcation Club. And we would like to stress the issue of provisional as a philosophy. I will speak more in my lecture, but for us, provisional is philosophy starting with single stent in the main vessel, and then if needed, you increase the level of complexity. So keep it simple as safe is a general rule in case you can finish with single stent. But even if you cannot finish with single stent, it's still provisional philosophy, because I'm just making things a little bit more easy to understand for your junior colleagues who attend probably. In this case, I may see this as something that will be treated at the end by two-stent strategy. But two-stent strategy having provisional philosophy in your mind. And there are two different approaches. One, I have to accept that I really don't clearly see everything. I would recommend in general for the left main image guidance to better understand plaque distribution and plaque composition as well, vessel sizes, presence of calcium, bifurcation angle. In left main, I believe use of imaging can always help. And depending on the findings on IVUS, there are two different ways. One is to put first stent towards the LAD, left main LAD. Because of the short left main, we definitely should cover from the ostium. It's really, at least in my opinion, short left main with 1-1-1 bifurcation. And after that, we open struts towards the circumflex and we do kissing. It's again provisional. And we evaluate result in the circumflex after kissing balloon inflation. If we see that result is suboptimal or it's intermediate, again, there are two options. One option is to do FFR because we have enough evidence that after main vessel stenting, evaluation of the functional significance of the side branch is actually the most important real indication to use physiology in bifurcation lesions. And then based on FFR, decide whether or not you need to stent the circ, or if the lesion is still tight and it's left main, it's big circumflex, large territory, definitely more than 10% of myocardial mass, you can use second stent in provisional fashion, which means because of the wide angle, you can do T-stenting, you can do tap stenting or culotte stenting. All three are in general variations which are based on the amount of stent that you pull back inside the left main. If you are crossing the most distal strut, if you do kissing, then probably T-stenting will be sufficient. If you need to pull back slightly stent from the circumflex inside the left main stent, then becomes T-stenting, tap stenting, variation with short protrusion, and if you pull more to touch the opposite wall, then it becomes mini culotte. So T-stenting, tap stenting, and culotte are two stent techniques, but are provisional strategy for treating bifurcations. The other options, because I'm speaking about provisional, because of the short lesion in both directions, in ostium of the LAD, in ostium of the circ. If you are experienced with double kissing crash, I know that people favor really recently after DK crash 5, people are using more and more double kissing crash. You can also do double kissing crash, stenting the circ, crushing the stent, and then stenting the left main and finalizing with kissing and final pot. So there are different options. All options should be based on careful evaluation of vessel size, plaque amount, distribution, and amount of calcium that is present. And then you make decision in which direction you put stent number 1, you do pot, you exchange wires, you do kiss, you evaluate result, and provisional is a layered strategy of complexity. You start with minimal complexity, which is stenting plus pot. Then if you are not satisfied with the result of the side branch, you can do kissing. You open struts towards the side branch, you do kissing, and again you evaluate. This is the second level of complexity. If you need second stent, you go to third level of complexity. You use two stents, but in a provisional fashion. I'm sorry if I'm speaking maybe in too many details, but you mentioned that you may have some younger colleagues, and
Yes.
I try to make this easier for them to understand.
Yes, and this is very clear, Dr. Stankovic, but I want to encourage the audience to throw in their questions in the chat box.
Yes.
So I highly encourage every one of you who has questions to type your questions briefly in the chat box so that we can entertain them as we go. And one question before we let Ali proceed, Dr. Goran,
Yes.
is so we go with this increasing level of complexity, starting with the notion of provisional. But decay crush is when you have assumed from the beginning that you're going to start with the two-stent technique, correct?
Exactly.
Otherwise, if it's in the provisional mode, it will be reverse decay, the reverse crush, which is not very much a wanted strategy.
Yeah.
But if you, let's say, if you have a 1-1-1 distal left main, ostial LAD, and an ostial circ, all of them 90%, big vessel. In that case, would you still consider provisional big artery 3.5, let's say?
Exactly.
Yeah.
Yes, because the only difference is whether I'm going to stent from left main into the circ, do the keys, and add second stent. If I'm afraid of losing the circ, I can stent inverted provisional, left main into the circ, pot, kissing, and then again T, tap or culotte from left main to the LAD. So I don't want to confuse people. For me, there is only one strategy in treating bifurcations, but those are the layers which are actually the way I'm approaching step by step, trying to stop at the level when I achieve optimal result.
Excellent. We have a question from Dr. Asim Javid. Your opinion about using drug-coated balloon for side branch and stent only the main branch?
Yeah, this is great idea. As European Bifurcation Club, we are trying to find a sponsor for study, which will in randomized fashion finally evaluate. All current evidence that we have comes from very small randomized studies from Germany. Those studies comparing stent main vessel versus stent plus drug-coated balloon in the side branch, unfortunately, were negative. So there is a lot of intuition behind using less metal in bifurcation. But we don't have firm evidence that such strategy is better for improving clinical outcome of our patients. Personally, I don't do it, but personally, I encourage, and I would like to see finally from any part of the world, big registry, well conducted, or in the best case scenario, randomized study, which will use these two strategies head to head. Like vaccines, everybody says which one is better. None of the studies so far head to head compared, so we cannot answer.
Right.
We don't know populations, we don't know who received, this is the same.
Excellent. So Ali, can you show us what you did, please?
Guiding, this is the guiding 7F guiding, UBU 3.5 guiding. I wired the left main and the LAD. Then I did first of all ballooning to the left main LAD. Then a ballooning also to the left main circ by a balloon 3.5 15 millimeter balloon. I checked the result. There were a slide, not a very well opening of the left main. After the injection on the spider view, we see there is a little bit of calcification on the ostial of the circumflex. For that, I redo by ballooning. I increase the size of the balloon by 4.515 to the left main LAD and to the left main circumflex with this final result. After ballooning by 4 times 15 millimeter balloon to the left main LAD and left main circumflex. Stenting.
Okay. So let's stop here for a minute and think a little bit. What are the options at this point? In the meantime, we have a question from Dr. Mohammad Al-Kabsi. Can we do left main stenting without IVUS or surgical backup? We can take this question either now or a little bit later. Ideally, I can tell you in Lebanon, many centers have IVUS, but I think the economic situation and in some cases experience is a bit in the way of using IVUS more liberally. Do we need surgical backup? We don't. In the past, we used to call the surgeon and make sure the surgeon is on standby. We don't do that anymore, and I don't think it's necessary anymore to do that. We just proceed. So let's go back to this here. You have what seems to be a good result in the ostium of the circumflex. So Dr. Goran, what would you? So this goes with your provisional thinking, I would presume. At this point, concentrate on the left main LAD stent and revisit the circumflex, see how it goes.
Yeah, I absolutely agree with you. The only difference is that if I'm planning provisional in such short lesion of the circ, I will not predilate, especially not with such a large balloon. Predilatation with 4.5, definitely, if you don't use imaging, increases the risk of dissection in that area. There is clear calcium which is present in the ostium. So now we have to decide to stent, and most of the time we stent towards the LAD, left main LAD. But the reason why we don't recommend routine predilatation of such a big side branch with big balloon is that when you predilate, you create dissection planes inside the vessel wall. And after stenting left main LAD, when you need to recross into the circ, you increase the likelihood of entering with wire in one of those dissection planes and then compromise the flow in the circumflex. This is, but this is not mandatory. Please, I'm just trying to give the options. Yes. I will do slightly different. I don't say this is wrong. To make a simple next step is stenting definitely towards the LAD in my case, but I would also agree completely if because of the calcium in front of the ostium of the circ, you would like to stent first towards the circ, do kissing, and stent towards the LAD.
Very good. So Dr. Sayed, show us what you did, please.
I take the strategy to do a crash technique. I stented the ostium of the left main a little bit, the circumflex with the protrusion to the left main with a balloon across, and I crushed the stent. Sorry. For Onyx 450 on the ostium of the circumflex with a balloon on the left main LAD, and I crushed the stent. Yeah, you will see it. No, I don't do it. I do the crash technique. Typically, the crash technique, I put the stent on the left main, on the ostium of the circumflex, protruded to the left main with the balloon present, and I take off the balloon of the stent, and I crushed the stent on the left main to do a crash technique.
Okay.
Sorry.
And then
this is I rewired the circumflex.
So obviously, you know, we're taught to wire in the distal strut. Well, with DK crush proximal, otherwise it's distal. I'm not sure. I'll ask Dr. Goran later. How feasible is this? When you get a chance, let us know if there are any tricks to know that you are truly distal when you want to be distal, truly proximal when you want to be proximal. Okay, so now you recrossed and you did your kissing.
And I kissing. Then I put my stent on the left main LAD with a wire on the aorta to be better cover the ostium of the left main. Then I did a final kissing.
So you recrossed.
Yeah, I recrossed and I opened the size of the stress of the circumflex by a balloon of 2.515, and I recrossed by 2 balloon, 4.15 on the left main, and then by the 2.515 on the circ, and I did a kissing balloon. Then I finished by a pot on the left main. And this is the final result.
Right.
If I can interrupt, Ali, you called it crushed technique, classic, and I've noticed that it is a mini crush because you've only protruded few strut cells in the left main, and this is definitely, I think, an advantage over the classic crush in the left main, if Professor Goran agreed with me, because you know that the stent segment which is trapped is shorter in the mini crush than in the classic crush, and this will definitely lead to less restenosis rate, less thrombosis rate, and especially in a big left main segment that we have in your case. Do you agree with me, Professor Goran?
Yeah, I absolutely agree with you, and I need to explain something. That kind of pre-dilatation was absolutely appropriately performed because I'm sure the decision to do mini crush was done from the beginning. So
yes.
Extensive pre-dilatation with large balloon is absolutely mandatory if you want to make sure that your stents will fully expand. So if you are planning to do double kissing crush or any of crush variations, absolutely mandatory step is to predilate in both directions to make sure that balloons fully open, adequately sized one-to-one. And in that case, you know that you will stent anyway the whole region, bifurcation, both branches. So I apologize for commenting against predilatation, but I understood later the decision was to do decay crush from the beginning, and this is absolutely appropriately done. What is, in my view, difficult to see here is the size of the pot. Balloon should be appropriately sized for the left main. In this angiographic image, I cannot clearly see the difference and step down in diameter from the left main into the ostium of the LAD, but I'm sure it was 4.5. What was the 5.0 or 4.5? The balloon size, the final.
Really, in this case,
Yeah,
I use a lot of balloon because every time for the first kissing and the later kissing, the balloon was changing every time. For that, every 4.5, 4.15 balloon what use it is for once, and we cannot use it for a second time. And for the latest, I put really a 4.0 12 balloon that I did the final kissing. I did the pot with the 4.0 balloon, and I go very high for the latest because I use like 8 balloons in this procedure. For that, I cannot afford to do more and more balloons. This is the situation with that.
Congratulations, it's excellent case. All the steps are properly done. In my view, what is missing compared to contemporary nowadays, I don't know when this case was done. Yes, I see in 2019. Today, there is a sequential crush. So you first crush stent from the circ using the balloon which is sized according to ostium of the LAD. So probably 3.5 or 4.0. After that, you use like the pot balloon and you crush again inside the left main with bigger balloon that you will use for the pot afterwards. So this is novelty. I fully accept this was not present at the time when this case was performed, but I believe, and I will show you visible heart images later on, in which you may see why it's so important to do proper crush with adequately sized balloon. Because with smaller balloon, we are not big enough to crush metal completely inside the left main. But otherwise, it's excellent. Regarding the proximal recross, it's of course angiographically very difficult to see. It's relatively easy to see if you want to cross distal strut, because when you jail the wire, when you implant the stent in the main vessel, for example, and you have wire in the circumflex, stent in the left main LAD will push completely laterally the jailed wire in the circumflex. So when you try to cross, you try to make distinction between two wires of 2 or 3 millimeters. Your wire for distal crossing should clearly separate angiographically for a couple of millimeters with the jailed wire. So this is one small angiographic trick. The other one, to make sure, and also for proximal, we use stent enhancement software. Stent enhancement software most of the time will help you visualize. But to be quite honest, I don't think that the cornerstone step of procedure is proximal versus distal crossing. As a philosophy, you do all you can, your best, to cross distally or in DK crush proximally. But you will not remove the wire if it's not really distally or if it's not completely proximally. You try to achieve, based on the bench testing, the most appropriate angiographic result. But in case it's difficult to really cross very distally, of course, you try to cross mid-distal, not the very distal cell.
So Dr. Goran, when you crush, and this is the question that we also receive,
Yes.
do you keep your wire in the left circumflex during crushing? I normally pull it out.
Yes,
and
yeah.
wire out. But if you want to know if you're proximal or distal,
yeah, it's a good marker.
you could keep it in.
Yeah, but you know, first of all, so I'm not a fan of DK crush, to be honest. And my good friend, Professor Shaoliang Chen, and I and myself are usually invited at many meetings in the world to have debate, provisional versus DK crush. But we are still very good friends. What I don't like is the complexity with 7 steps, and you can make mistake at every step. And it's sometimes very difficult to repair if you omit something. And that's why I like provisional as a philosophy. And I'm starting with less complexity and adding complexity only if it's necessary. But I'm not against DK crush, please don't misunderstand me. For diffuse lesion length in DK crush 5, in the circumflex, mean lesion length was 16 millimeters. We know from the Benestan study 25 years ago that for such diffuse disease, 16 millimeter, stent is better than balloon. So it's not fair to compare in such diffuse disease of the circumflex, balloon versus stent. Of course, stent is better. We know it's better, and I don't see any reason to repeat study which shows you something that we learned in 1994. For diffuse disease, stent is definitely better. 2-stent strategy, whatever technique you like, you practice regularly and you are familiar with. Every technique, if it's done step by step, will give you optimal clinical outcome, but you have to finish 2-stent technique with final kiss, and that's absolutely mandatory.
Absolutely. Thank you so much, Professor Goran.
No, thank you.
It was absolutely superb. Thank you. So I think we'll move. Oh, you have more to? Okay. Yeah, go ahead.
This is 6 months after the stenting. We control it, and there was a very good result after 6 months.
Dr. Ghazal, if you allow me, like a remark for or a question for Dr. Stankovic.
Yes.
In retrospect, taking this picture which we had after stenting, you will insist on doing provisional left main LAD, see the result of the ostial circ after ballooning, because we noticed from Dr. Ali, while he did the ballooning for both segments, the result was superb. If you noticed, there was a good flow and wide open ostial circ using the balloon dilatation he had. So you can imagine that if you had started with the left main provisional LAD stenting and see the result on the ostial circ, you will just end your procedure having a balloon dilatation and assess the result. If no dissection, good flow, you will end it without putting any other stent.
Exactly, because if the residual stenosis is less than 70%, if there is no flow limiting dissection, we don't have any valid evidence that for short lesion, shorter than 10 millimeters in the circ, we have better clinical outcome by putting second stent.
And you've started this, yes, you've started this mentioning your strategy because the ostial circ lesion was focal.
Yes.
It wasn't diffuse.
That's the main difference.
Yes.
In DK Crash 5, they had 2 centimeter long diffuse disease. Everyone that I know, and in my hospital, we have 10 operators, everyone will use 2 stents. It's just the difference in the sequence if it's 20 millimeter long lesion. What I'm trying to share as my personal opinion, but also as an official statement of the European Bifurcation Club, shorter than 5 millimeter, if the result after kissing balloon inflation is adequate, in ostial left main because of the stenting, to correct longitudinal deformation probably created by guiding catheter, we should finish with final pot, flaring the ostial part of the left main stent. And that's it. And in that case, I will do provisional. But if it's diffuse disease, I fully accept and I have great respect. This is excellent case. Angiographically looks beautiful. We absolutely believe that procedural result, which is optimal, ensures good long-term clinical outcome.
We have several questions. I'm not sure we're going to have.
No, I'm very happy to answer.
Too much time for that. But from Dr. Raed Asman, is CoroScan helpful to evaluate calcification in this case? I think really when we're in the lab, probably better if we have OCT or IVUS to really help us be guided with this. And and unfortunately, these type of equipments are scarce in Lebanon. Dr. Aldi was asking if the circumflex lesion was about 50 to 60%, would you balloon it before stenting? So of course, it also depends on the length of the lesion.
Exactly, but also on the, as I said, personal cascade of events that you have in your mind when you do provisional. If it's 50 to 60%, I personally will not predilate. But after kissing, if I'm not happy, I will put second stent. But I try to explain, I don't like to increase possibility of having dissection because this will change my strategy towards stenting the side branch.
Yeah, we'll take one last question from Dr. Randa Tabba. How do you choose the main branch to stent first when treating a left main bifurcation?
Yeah, so thanks for that question. I think it's extremely important. Most of the time, left main LAD is a main vessel. Left main LAD, because it supplies majority of myocardium of the left ventricle. It's when we treat bifurcation predominantly for optimal result in the main vessel, which is LAD usually. But in case that we have huge amount of calcium in front of the ostium of the circ that we would like to compress with stent, then we do inverted provisional. We stent from the left main into the circ, compress that plaque, and then do kissing and, if necessary, second stent in the LAD. Or if there is myocardial infarction with scar of the anterior wall and lateral wall is the very important viable myocardium, in that case, circumflex becomes the main vessel, so we stent in that direction. All the steps are absolutely the same. You always do the same. 2 wires, pre-dilatation of the main vessel or the side branch, stenting of the main vessel or the side branch, pot. After pot, we evaluate. We stop first time after pot.
Yes, thank you, Dr. Goran. I think we'll move to, we have more questions, but we'll try to get them later. We'll move to the next talk, which is going to be my talk. So if I can share the screen, if you can unshare your screen, Ali, and I will share my screen. Okay. Okay. So I called it bifurcation stenting. You can all see the slides?
Perfectly well.
Yeah. Bifurcation stenting, frequently asked questions. So I posed, a couple of questions, and then which we will tackle very quickly at the beginning, because I think the last question I have is probably very pertinent to the discussion of, to a very contemporary discussion. So one question is as follows: when you do, so yeah, this is a left main, distal left main lesion, you do a crossover stent, and the circumflex vessel, which in this case, let's say is a 3.5 millimeter vessel, is jailed, but you either don't see any lesion or you see a mild lesion or FFR more than 80. The question is, when do you feel compelled to open the circumflex struts in order to facilitate future access? So if Dr. Goran, you give us your opinion on that.
Yes, and again, as from the beginning, I'm trying to share my personal understanding and way I'm performing these procedures. And most of the time, I follow the guidelines of the European Bifurcation Club. I participated from the very beginning, since 2004. 6 of us actually created Bifurcation Club. Yves Louvard, Thierry Lefebvre, Olivier Darmon, Remo Albiero, Manuel Pan, and myself. These are 6 people who created the club. And from the very beginning, we discuss extensively, and then we try to make consensus, and then we back up that consensus. So circumflex is extremely important vessel. In 95% of cases, according to CT, it supplies with blood relevant myocardial mass of the left ventricle, more than 10%. So it's clinically relevant side branch. For all clinically relevant side branches, our goal is to provide optimal result at the ostium after stenting, but also to make optimal access or open the door for future intervention or disease progression in this stent in the circ that was in previous patient, or disease in the marginal branch. So someone else, instead of me, needs to remove the struts 6 months or 16 months later if disease progresses, and this guy definitely has diffuse coronary artery disease. So according to randomized studies, there is no benefit of routine kissing in provisional, but very importantly, there is no penalty for performing final kissing in provisional. So you don't improve, but you also don't harm. And I was trained with Dr. Antonio Colombo. I worked 3 years in Milan with him. And I fully believe that every large bifurcation should be finalized with kissing. So whether it's acceptable for you or not, I finish all left main PCIs provisionally with final kissing. And I believe this is the good way to proceed.
Excellent, very clear, Dr. Goran. So let me take you to the other scenario.
Yes.
So now we have this left main LAD and circumflex, and again, a crossover. But the question is, we have this ostial left main, And what is the best way to position the stent in order to avoid significant protrusion and at the same time not miss the ostium? And what is the best way to re-access a protruding stent? I'm going to just go through a couple of slides
Sure.
just to illustrate a little bit. So how do we make sure it doesn't stick too much? This is an example of an ostial left main. And again, since we're talking bifurcation, imagine if this was part of a bifurcation, but you want to land your stent in the ostium. What would you do it? Here, the views are extremely important. For example, this view is not a good view. You see that the cusp, the dye and the cusp is overshadowing the left main and where the left main extends. On the other hand, if you use a cranial view, usually I like an LAO 10 cranial, 10 LAO, or you can even have an areocranial. Then you can see much better. But look what may happen. Here you're trying to place your stent perfectly well in the ostium. This is the cusp. This is the takeoff of the left main. And notice how typically it's bevel type inlet. So it is not a square inlet. Our stents are square cylindrical. They're not beveled. So when you want to cover this top part, you're going to have protrusion in the lower part. You cannot avoid it. The key thing is not to go too, so this is the result, for example, on this type of stent, but the key is not to go too much into the aorta, because then it would be too difficult to rewire. This is an example from the literature of this was a stent as per the case report that was placed during an emergency. Patient did well several years later, but look how much protrusion there is. And if there is that much protrusion, it's almost impossible. And I would like to hear the rest, the panelists, if they have any opinion on that. It's almost impossible if you have to come back to re-access it coaxially. It's almost impossible. In fact, you can even, in this example on the left, you see it how it's generously protruding into the left main. You even see it by 2D echo. And here on the right, I think this was from a Chinese medical journal. I can't remember which one. But here they had to re-access. The only way they could do it is by accessing through the sides of the struts of the stents, which brings it a higher level of complexity for later on, using OCT and IVUS. So it's very important not to let it protrude so that you can access it if you ever have to re-access it. Any comments on that? Or else maybe I can proceed to the next, to my final frequently asked question. This is going to take just a few minutes, but it's actually quite interesting. The question of triple therapy post-bifurcating stents. So, and I'm going to just throw questions to the audience or to the panelists. When you have, let's say, a complex bifurcating stent, patient comes in on let's say rivaroxaban because of AFib. He has AFib, rivaroxaban, and now you're placing 2 stents in a bifurcation. What would you do as far as triple therapy? So can I have, for example, Malek, how would you, today when you have that scenario, your patient is on 20 milligrams of Xarelto, you finish your bifurcation, you're on aspirin and let's say clopidogrel or aspirin and ticagrelor. How do you continue?
Yes. First of all, this is a scenario of usually atrial fibrillation case with the PCI, which is found in around 10 to 15% of cases, even up to 20% of our cases will have this scenario. And definitely, I will not go over 1 month triple therapy. This triple therapy, I will definitely give the clopidogrel instead of ticagrelor with low dose aspirin 75 to 81 milligram and NOAC or DOACs instead of the vitamin K antagonist, which is really a mess in INR role. So after 1 month at most in a complex bifurcation left main stenting technique, or definitely this patient has to be with a low bleeding tendency. His should be low. He'll definitely be a low risk for bleeding. Give this 3 combination even for 1 month, or else if he is not in this complex scenario and not in ACS, I will definitely give for 1-2 days, maximum 1 week, and then shift into dual clopidogrel with the DOAC for 6 to 12 months, according to the state of the stability of the patient. And then definitely I will drop the P2Y12 inhibitor and keep him on alone DOAC. This is usually the scenario, and we were backed up few days or few weeks ago by the consensus from the American College of Cardiology on this triple combination shifting into dual in different scenarios of these patients.
Excellent.
This is my opinion.
This is really superb, and you've almost summarized what's in that consensus. So the consensus, and I'm going to take you through it quickly. The consensus came last month, actually, was released last month on this very important topic. The consensus reminds us, and this is very important, that the addition of single antiplatelet therapy to an oral anticoagulant, so even if you are on a single plus an oral anticoagulant, you increase the risk of bleeding by more than 20 to 60%. And the addition of dual to an oral anticoagulant further increases the risk 2 to 3-fold. So it's very difficult to be on triple therapy. The bleeding risk is quite high. And how high? The major bleeding risk with triple antithrombotic therapy. Today, we have many of our patients on triple antithrombotic therapy, and we have to really rethink it, because the major bleeding with triple antithrombotic therapy can be as high as 2.2% at 1 month and 4 to 12% at 1 year. So this is a lot. And because major bleeding is associated with an up to 5-fold increased risk of death following an acute coronary syndrome, it's important to identify the optimal antithrombotic therapy. So it goes through, this consensus goes through those very detailed algorithm, but I'm going to simplify them for you. First of all, you have to make sure of the indication of the oral anticoagulant. Okay, you can't just accept the fact that the patient has AFib and is an oral anticoagulant. You always have to scrutinize it by the current Heart Rhythm Society ACC-HA recommendation that men with a CHA2DS2-VASc score of more than 2 or more and women with 3 or more take an oral anticoagulant. And that's what the consensus said. The general theme of the consensus is that overall, we recommend against the routine use of triple antithrombotic therapy for most patients. And accordingly, for patients requiring both an anticoagulant and an antiplatelet, we strongly recommend that the default strategy after recent PCI be dual antithrombotic therapy consisting of an anticoagulant and a P2Y12 inhibitor. So basically dropping the aspirin. And we always start, as per the ACC-HA recommendation, with a low dose aspirin, loading with 162 to 325 milligrams. However, we continue with the low dose aspirin, typically 81 to 100 milligram. The general theme of this consensus, when you are tackling the possibility of triple therapy, is to go down to double therapy after about a week or during or finish your aspirin for the duration of the hospitalization. After that, You continue with your P2Y12 inhibitor. They prefer clopidogrel. They prefer clopidogrel except in certain instances. And you continue with your anticoagulant, like Malek was saying, they prefer DOAC over vitamin K antagonists. Why? Many reasons. It's simple. It is more. You can expect more out of it, and the most important thing, there is lower bleeding risk. So it is more, the word I was looking for, it is more predictable. So it is simple, predictable, and lower bleeding risk in studies that have compared to vitamin K antagonists. And radial access is recommended. Now, if you have a high stent thrombosis risk, either ACS or let's say, for example, bifurcation stenting, and especially if it involved a left main and low bleeding risk, you may consider continuing the APT for 30 days rather than dropping the aspirin after discharge. You drop it after 30 days. And ticagrelor in this case, because of high stent thrombosis, may be used in lieu of clopidogrel as the P2Y12 inhibitor of choice. And after 1 month, you continue only with oral anticoagulant and P2Y12 inhibitor. So the consensus does not go beyond 1 month of triple therapy. And this is here with high thrombosis risk and low bleeding risk. And how about the duration of the P2Y12 monotherapy? Typically, 6 months for stable ischemic heart disease and 12 months for ACS. I'll come back to that. And for patients requiring indefinite anticoagulant therapy, that's patients, let's say, with AFib. By the way, the consensus considers AFib, considers people with venothrombotic events or cerebrovascular events who are on anticoagulants or otherwise. But here I'm focusing on the AFib patients because this is commonly what we see. So typically here, the antiplatelet should be continued for 1 year post PCI. So what do we mean by that? We just said that for stable ischemic heart disease post PCI, we use 6 months of P2Y12 inhibitor. So here they say for stable ischemic heart disease, you go 6 months with your clopidogrel, or let's say with your ticagrelor, and then the next 6 months you continue with either your same P2Y12 inhibitor or aspirin. Why? Because there is no data on just single on oral anticoagulant alone, even if you have stable ischemic heart disease. And then after that, it's only anticoagulant therapy. No aspirin, no clopidogrel, no ticagrelor, okay? And if you, I think this we went over that, for patients with high risk of bleeding, if you have high risk, you can discontinue the single antiplatelet therapy before the recommended duration can be considered. So that would be 3 months for stable ischemic heart disease and 6 months for acute coronary syndrome patients. You always weigh the risk of stent thrombosis versus bleeding. Here, for patients who are not candidates for DOAC and require treatment with the vitamin K, it's reasonable to aim for a lower end of the target INR range 2 to 2.5. And for patients on 2 or more antithrombotic agents, they recommend starting or continuing a PPI along with avoidance of concomitant non-steroidal anti-inflammatory agents. And once you are on a single agent, such as the anticoagulant alone, then you remove your PPI. And in terms of primary prevention, we have a lot of our patients based on ACC/AHA guidelines on low-dose aspirin for primary prevention that might be considered for the, if such patients were to develop AF requiring oral anticoagulant, then the appropriate management is nearly always to stop your antiplatelet agent. So if you're on aspirin and now you have AFib, you start your patients on a DOAC, let's say, or even vitamin K, you stop your aspirin. Okay, so that's really, I think, quite a considerable change from the way we've been practicing. So if you have AFib that comes after you place your stents for a stable ischemic heart disease, this is what's going to happen. So you placed your stents in a stable ischemic heart disease patients, you start your dual antiplatelet therapy. Let's say at month 4 or 5, your patient develops AFib. Then you stop your aspirin and you start your oral anticoagulant. Okay, but let's say that AFib started at, let's say, 8 or 10 months. Okay, then you're still within the 12-month. Then you start your oral anticoagulant. Now you continue with a single antiplatelet. It doesn't have to be a P2Y12 inhibitor. You can choose aspirin or continue with your P2Y12 inhibitor. Before 6 months, you continue with the P2Y12 inhibitor. After 6 months, you can continue with either or of the antiplatelet agents with the OAC. And after 12 months, then you continue with your oral anticoagulant alone. If, for example, your AFib comes after an acute coronary syndrome, so you've placed your stents already in an acute coronary syndrome where you committed to 12 months, then you stop the aspirin and you continue with the P2Y12 inhibitor with preference given to clopidogrel. And then you start your oral anticoagulant with preference given, as we said before, to the direct oral anticoagulant or novel oral anticoagulant. And if it's been more than 12 months, then the antiplatelet patient's medication can be stopped altogether. You just continue with your oral anticoagulant. So that's what I wanted to share with you, and I'll be interested, Professor Goran, if you have any comments on that topic.
Yeah, thank you very much. But this was great presentation, really covering everything. Whatever I say, I will not have anything practical to add to this.
Very good. So we'll move to the next presentation. Gilbert, are you ready? Dr. Gilbert Abi Nader is going to show us a case, and then we'll go back and see about answering more questions from the chat box.
Sure.
Good evening. So, say 50-year-old man.
We can't hear you well, Gilbert. If you can just come closer to the microphone.
Okay. So this is a 50-year-old man presenting with non-STEMI. He has comorbidities, diabetes, hypertension, dyslipidemia. He's a heavy smoker. He has morbid obesity with sedentary lifestyle. At presentation, his EKG and echocardiography were normal. So an angiogram showed a really type A or B1 lesion in RCA. But he has on the left his left main is normal. He has 50% at mid LAD. The distal LAD is mainly infiltrated. However, he has a large caliber vessel circumflex, giving rise to one large obtuse marginal branch, verso M1. And as you see, also the posterolateral branch, you will see it also in another another view. It also has a tight lesion here distally, the PL. He basically has a codominance. So in the cranial views, you see also that the OM, the ostial OM, also is significantly involved. Has also distal posterolateral stenosis here. Distally, the PL is also has a tight lesion. The LAD stenosis was not hemodynamically significant. So here we see a Medina 111 lesion taking the mid-circumflex ostial OM1. And we have large caliber vessel. We're speaking of calibers 4 and 4.5 at least millimeter caliber vessels. So
Excellent. Okay.
what do you think about the strategy? Which vessel we should consider it as the main? Which one, like the branch? One stand technique, two stand technique.
So let's hear from Dr. Goran. If you
Yeah, no, of course, with pleasure. But you know, again, I can share only my personal perspective. In my view, because of unfavorable angulation and most of the plaque on the lateral wall towards the distal circumflex, I would, of course, my strategy is provisional. It's simply a philosophy that I'm using all the time. And after putting both wires, my stent will go towards the distal circ, kissing evaluation of the result in the obtuse marginal. Lesion in the obtuse marginal is tight but extremely short. Much more diffuse disease is present in the after bifurcation. And my strategy is therefore straight stenting, pot, wire exchange, kissing, and then evaluate the result again. I think this could be finished with seems like single stent strategy.
Okay.
Also, Dr. Goran, also depending on the focal lesion which is found on the ostium of the bifurcation.
Exactly.
That's it.
Because it's really tight but very short, and very short, very well responds to balloon dilatation.
To balloon dilatation.
Dr. Goran, so if I want to connect the dots on what you've been commenting on,
thank you.
You don't like the DK crush too much. I don't like it either. So that's why you're even more comfortable always going with provisional, because you eliminate the DK crush from the beginning, because DK crush is for two-stent strategy anyway. So I think that perfectly makes sense. You know, I mean, this approach, you know, this approach is quite reasonable, and even in this case, you would try the provisional approach. So Gilbert, tell us your reasoning here.
So as usually, like the strategy of bifurcation treatment is to assess the side branch. It's need to be preserved, of course, needs to be preserved because it's a major branch and supplying a large myocardium. So is there any likelihood of side branch occlusion? Yes, the likelihood is there. We will try to do provisional. However, there is also a chance to jeopardize this the other branch, the daughter branch. And so this is why we will keep also in mind the two-stand technique in the two-stand strategy in case needed. And as a two-stand technique, the usual and the very common is the T-standing, tap, DK crash, or culotte. So me too, I don't like the DK crash because of I tried it many times, and like 50% of the time I've had really difficulty to rewire. Sometimes I use a micro catheter to rewire, and I never be sure like 100% I'm safe. My wire are okay. So I said I will try to be provisional if I can. However, in case it doesn't turn good, so I will do here culotte, because usually I use the T technique or tap technique when the branch is not the very large caliber and not doesn't have the same caliber as the main branch. So in this time, I said I will, in case I will use two stents, I will use the culotte technique. So culotte also it consists in 11 steps. I never consider it's complex. The rewiring usually is easy, and almost 100% of the time, usually we're speaking about the large caliber vessel, you have a good result. So also when I was reading, also I found this double kissing culotte technique for coronary bifurcation stenting is to double kiss, because you will have lower risk of malopposition rate when you use the DK culotte in these branch data, test data. And sometimes it will make your life much easier.
So here
of course we rewire.
You decided, Gilbert, on a two-stent technique, and you chose to go with the culotte.
I tried to initially. I said I will try provisional.
Okay, okay. Because culotte.
In case we will need two-stent technique, I will use culotte.
Okay, because culotte you can use it with.
Yes, you can do it without double kissing, of course.
Yes, yes. Yeah, I was saying culotte you can use it with,
yes.
with either techniques,
so,
provisional or.
But sorry, Ziad, but if you want to go provisional, then you will go stenting straight in from the proximal segment straight into the distal main branch, and then with the culotte, it is advised to go first with the most angulated segment, which is opposite to this provisional.
If you see here,
isn't it?
This region.
Yeah, the most angulated is the OM2.
Let's say the circumflex.
Yes.
I name this circumflex, and this is OM1.
Yes. If you want to go provisional, you will go from the proximal down to OM1, leaving the wire jailed in the OM2.
No, I don't think you can leave the circumflex or OM2 on provisional.
No. I know, but you said you started provisional and you want to escalate or not according to the result. If you are planning to go culotte, you should go first stenting the most angulated segment, but with the provisional, you've put your stent first in the straight segment.
In provisional, this is a main branch. So I put my stent here, and I do kiss here, and after I reassess.
So he's starting with the most angulated, stent into the most angulated.
Dr. Goran, with your provisional approach, you will go straight from the stent in the proximal down to OM1, isn't it?
First
if
of
you
all,
if you want to use provisional approach,
both directions.
You will stent the OM1.
No, I just tried to explain. OM1 has extremely short lesion, so this will be inverted provisional, but it's still provisional. Whatever direction you put stent, it's either provisional or inverted provisional with possibility to use second stent. So DK crash is if you go with two stents from the beginning. Directly, yes.
Okay. So if I just for the audience to make sure we sum up the discussion here. So the most angulated branch is the continuation of the circ, is the one going down. That would be the most difficult to wire. So if you put your stent into the first one, the straight one, it would be more difficult provisionally to reaccess the one which is with the most difficult angle. The other thing, I want to make one more comment. It so happens that both branches are big enough. The OM is big. The continuation of the circ happens to be smaller, but two significant branches coming out of it. So as far as the weight of the myocardium, because this will also take it into consideration when you have the choice of going one versus the other. You don't want to go into one that's small, save the one that's small. You don't want to save one, let's say, that's infarcted and has not supplying adequate myocardium. So here they're equal. So go ahead, Gilbert, and show us what you did.
Here, actually, immediately after wiring both branches, the patient started to have
Chest pain.
severe chest pain with hemodynamic compromise. Had to pre-dilate quickly the circumflex with 3O by 12 NC balloon, followed by implantation of a 4.0 by 24 millimeter stent. Immediately after the takeoff of, immediately after the aneurysmal formation of the circumflex. So going toward the landing, a good landing zone of the circumflex, inflated. Patient chest pain was always present here, so we have to open up the, rewiring the marginal and opening of the struts with the 3O balloon. After that, I said I need to treat also the distal posterolateral branch before performing any complex procedure. I tried to advance a stent here,
Difficult.
but it was difficult to
Cross.
track it down. So I had to make kissing before going down. I made a kissing. Maybe I didn't take the shot here, but I made a kissing at the bifurcation, so I could advance the stent distally to treat the posterolateral lesion. So this was followed by a kissing here.
So what
Kissing
size
balloon.
balloons? Do you remember what size balloons do you have here?
4.0 by 3.5. 4.0 by 3.5.
Wow.
And 4.0, of course, toward the circumflex, and 3.5 toward the marginal. Followed by pot with a 4.5 balloon. So I didn't like the result here. I had some doubt to have some dissection or
So
critical
let's,
lesion.
yeah, let's pause here for a minute, Gilbert.
Yes.
So you dilated. Were you enough into the first OM as if your balloon was right at the ostium? But anyway, so this was after dilatation with a 3-5 balloon in a kissing
Yes.
mode, and you were well into the ostium, and this
Yes.
is the result. Okay, this
Yes.
is the result. Okay, so you stented it, but before stenting it, Professor Goran, so this is your provisional strategy. You have this kind of result.
You know, if you, sorry for making this a little bit more complicated. Can you go back to final pot? One slide back. No, this one is perfect. Just go once. Yeah, that one. Look the position of the balloon. It's beyond carina. So lesion that you see afterwards is combination of carina and plaque shift. A little bit less distal position of balloon would probably avoid a lesion that you see after. Now you go to the next one and you will see the lesion. So in my view, this is a combination of carina and plaque shift, and the distal position of second pot was actually creating. So in this case, I would redo kissing and do more proximal pot. And if result is still like this one, then I will go for second stent.
Okay. So the patient was always in pain, despite morphine, despite nitrate, despite everything.
Sure.
So I thought actually the pain is from the ostium of the marginal artery.
You have a good lumen.
Mm. So I decided to put a stent in a culotte manner. Here, I don't know. Sometimes some people they keep the wire in the circumflex. Okay, between two stents. Other people they don't put a wire. Here it was not a concern because The lumen actually of the circumflex, I didn't have a fear about that because it's a
Big
very
one.
large lumen. So I preferred not to have troubles with wire. So I withdraw the wire. And this is another stand 4.0 by 12 millimeter inflated at high pressure. Then rewiring of the circumflex through the stand of through the struts of the second stand. Opening with a 4.0 by 12 balloon gradually, actually, with a smaller balloon. After that, a 4.0.
Did you start from the
Kissing.
beginning, big one, or
No.
you tried the big one? It
No,
didn't. Okay.
didn't, because it was used actually.
Yeah.
The balloon was used before. So I took another smaller balloon, and this is another kissing 3.5 by 4.0, inflated at high pressure, followed by repot. And this is the final result.
Excellent. Very, very good. Professor Goran, if I may ask you, Gilbert did the final kissing with a 4.0 and 3.5, correct, Gilbert?
Yes.
4.0 and 3.5. Do you remember how high you went?
I went actually very high
Nominal.
with the 3.5. Then I inflated the 4.2. I had a fear to inflate actually the 3.5 and 4 proximally. This is why I did it low pressure initially 3.5, then high pressure 3.5, then low pressure 3.5 and 4.2 high pressure.
Okay, so Dr. Goran, here comes always these practical questions that we would like your thought on. When you do the kissing balloon inflations post stenting, okay, there are many questions that come to mind. First of all, as far as the sizing, knowing that when you add, let's say, 2 stents, a 3.5 plus a 4.0, normally the proximal vessel is 2/3 of the sum. But at the same time, the diameters actually are next to each other. Some people say it makes a D-shaped curve on each other, and therefore it's really not 7.5. And then the other thing, so I would like your comment on that. And the other thing is, how high do you go? And any practical tips you can give us there?
Sure. Thanks for that question. It's very important to understand that diameters of balloon should be reference diameters of distal part of the main vessel and distal part of the side branch. So in my view, maybe 2 times 3.5 will be in my case. Still, you see it in the cut lab maybe better. I don't think that makes a big difference, but I have impression that using too large stand diameters and balloon diameters create carina shift, which compromises the other branch each time. So in my case, 2 times 3.5, what is important is we use short non-compliant balloons. When both vessels are stented, when you inflate simultaneously, diameter of the overlapping segment of 2 balloons is full diameter of the big one plus 1/3 of diameter of the smaller balloon. So in this case will be 4.0 plus 1/3 of 3.5, which is 1.2. So in the overlap part of the proximal main vessel, you will have 5.2, which is in my view maybe too large for this vessel. But you know, operator in the lab better can see it, and definitely there was judgment by experienced operator. Okay, first I want to say that case was done really with all steps of the culotte, and I congratulate on excellent performance. In Europe, we also like culotte more. So how to do kissing? We start usually by inflating separately, side branch, main branch at very high pressure. So separate inflations, non-compliant balloons, high pressure. To fully open, remove all the metal from the ostia and make maximal separate inflations. And then for single inflation, you go to high pressure. For kissing and simultaneous inflation, you don't need high pressure. With kissing, what you achieve by simultaneous inflation, you
Nominal.
position carina in the center. That's the main benefit of kissing, that you position carina in the center, which is optimal for the flow. Second, by simultaneous inflation proximally, you expand better main vessel proximal segment. So in this case, what I will do different is maybe use slightly smaller balloons and more proximal position of the final pot. Otherwise, everything was done by the book.
Excellent. Let me just take a couple of
Sure.
comments or questions. This was really a superb case. So Dr. Abani reminded me something very important. In the talk that I gave about triple antiplatelet, triple antithrombotic therapy, reducing it to 2, it's very important to remember that this applies only to the latest generation stents. Okay, so that's very important, and that's good. Dr. Omar Shabo was asking about a question about doing kissing balloon. Is there a way? Is there a situation where you use smaller balloons than your stents when you do kissing?
No, absolutely makes no sense to use smaller balloons than stents.
Okay.
Because each time you are using smaller balloon than stent, the other balloon will crush and compress the stent. So you decrease the stent lumen area, and this is not good.
Yeah. And Dr. Alex Karma was asking, is pot mandatory after the kissing in this case? So,
but you know, we don't have clinical evidence that pot is mandatory, and we have a lot of evidence that with distal position of pot balloon, you can compromise the result of kiss.
okay.
So I don't think it's 100% needed.
Okay, Dr. Rami Dad was asking about the stentis stent for left main.
But you know, personally, first there is no study really showing the superiority of that kind of platform. Self-expandable platform, or the more recent balloon expandable platform, never had result which is better than classical latest generation DES. And I don't like the disconnecting the struts of the stentis, because in case you are disconnecting proximal strut, then you will have metal inside the main vessel stent. So it's very important with stentis to disconnect distal strut.
Very good. Dr. Aldi, I guess relevant to my presentation, how about resistance to clopidogrel? This is a very important question. So even though the consensus document falls back and prefers clopidogrel, part of the triple then becoming dual antithrombotic therapy, actually they do mention that it is not necessary to rely on the clopidogrel resistance test, the point of care testing for platelet reactivity, because the data there is not very helpful. So what they're advising about clopidogrel is irrespective of trying to find out or not finding out resistance to platelets. Resistance to clopidogrel. So now, Dr. Goran, we're ready for your presentation.
Thank you.
If Dr. Gilbert can unshare his screen.
Sure.
And Dr. Alam, by the way, sends his greetings to you, Dr. Goran.
Oh, thank you so much.
Dr. Samir Alam.
Yes. Please give him my best wishes from Belgrade. He was our guest at several Bifurcation Club meetings, always with nice comments, with a lot of knowledge of the basic characteristics of flow And we really learned a lot from him, and I really wish to see him again when we have next time Bifurcation Club.
Great. He's with us now on this
Oh,
webinar.
fantastic. I'm so happy that he's there. So if you allow me, I can start my presentation, try to make it as clear as possible. Please feel free to interrupt me if you have any questions. So again, thank you very much. I enjoyed immensely this part of the webinar so far, and I hope that my presentation will be also helpful for yourself. So this is the flow, and when we speak about bifurcations, I have to speak about my only conflict of interest, which is being board member of the European Bifurcation Club. This is the first Bifurcation Club meeting in 2005. You see how younger all these guys who are big names in bifurcation PCI procedures nowadays. And the last meeting we had was virtual meeting on 22nd, 23rd of October. But I'm really happy that we received excellent support from very good friends all over the world. You will see the board. So it's Yves Louvard, it's Thierry Lefebvre, it's Francesco Burzotta, Tom Johnson here, myself, again, Yves, Jens Lassen, so Manuel Pan, and also friends coming from all parts of the world. Even for the first time, we had also Greg Stone and our regular participant and really good advisor and friend, Professor Patrick Serruius. We recently participated in creation of the Sky Bifurcation Club. This is the current president, Dr. George Dangas, and I'm happy to be invited to help him to build the club, and I'm member of the club. Also, Vlad Javik, president of the Canadian Bifurcation Club, and as you can see, Ricardo Costa from Brazil, Sunao Nakamura and Murasato from Japan, Ronnie Matthew from India, and all other really big names and good friends and colleagues. So I'll try to summarize EBC ethos of treatment of bifurcations. As we said in the beginning, we try to make it simple and safe. We try to limit the number of stents, and we try to respect the original bifurcation anatomy, and we try to reproduce it with tubular stent. So we aim for well-opposed and well-expanded stents with limited overlap. But of course, we are aware that in case of complex anatomy and diffuse disease of both main vessel and the side branch, we should consider upfront two-stent strategy. And what I already commented, and I will just briefly go through this one. So in our view, provisional stenting is not single stent. Provisional stenting is the standard approach, including the left main, but it's actually strategy or philosophy rather than simple single stent technique. We start with main vessel stenting, respecting distal main vessel diameter. We do pot to respect original tapering anatomy and to open struts towards the circ. And then we evaluate. This is the first layer of complexity. Second, if the side branch is compromised, we continue and dilate. If results is better, we repeat pot and we stop again. If side branch is still compromised, we escalate to the side branch kissing and stenting, and we believe that this sequential stenting strategy starting from low complexity and going to higher complexity is very appropriate and applicable for vast majority of bifurcations. And I like very much the funny comment of Jens Lassen. He said once, if you start with single stent, you can always add a second stent. But if you start with two stent strategy from the beginning, you will never end with single stent. These are the EBC for years standard steps of provisional. Always wire both branches, predilate the main, but of course side branch dilatation is operator decision. You may or you may not need to do it. Stent according to distal main vessel reference and do pot. Pot is mandatory step, and then kissing is optional, as I said, for the large side branch, and this is standard approach. You can do pot, kissing, balloon inflation, and pot. If you use second stent, then kissing becomes mandatory. This is Visible Heart Lab. This is Pig Heart, and we do it in cooperation with University of Minnesota and Medtronic, and European Bifurcation Club cooperates closely with Medtronic in understanding from this bench testing, in vitro testing, what are the mandatory steps and what are possible pitfalls. So to do pot, you see, you go with distal marker just in front of carina, you select a length of the balloon which is adequate to cover the whole proximal segment and diameter according to proximal main vessel diameter. If you properly do pot, you can see here that we have, according to OCT, optimal apposition of the stent in the proximal part, which is the key to reduce further events. I already spoke about this, but this is good illustration. So if you decide to do final kissing balloon in provisional, you use two non-compliant balloons, short, sized according to distal reference of the main branch and the side branch, with short proximal overlap, because with longer overlap, you create oval shape deformation, and in that case, you should consider repot. We start sequentially by inflating side branch balloon first. We go to 10 or 12 atmospheres, then we start by inflating main vessel balloon, and when we reach 10 to 12 atmospheres in both, we deflate simultaneously. Simultaneous deflation is very important to keep carina in the center. This is my cartoon which I made with my colleague Dr. Zlatko Mehmetbegovic to help people understand the steps of provisional. So wire both branches, predilate the main, stent the main vessel according to distal main vessel diameter. You see, it's not opposed. You do pot, and in all cases worldwide, I still don't see pot as a regular part of procedure. After pot, we do kissing, and then we repeat pot, especially in the proximal edge, to make sure that stent is fully opposed. And you see, with tubular stent, by doing these steps, you create two diameters. Fractal geometry is recreated with single stent, with nice opening towards the side branch, big diameter proximally, adequate small diameter distally. However, for elective two-stent strategies, we put as indication, as I said, long diffuse disease of the side branch, or high risk of side branch compromise, or difficult access to side branch. However, when we plan two-stent strategy, we should again advise provisional stepwise approach and finalize putting second stent as a crossover from provisional using T, TAP, or culotte. However, we have enough evidence that for the operators with appropriate experience, double kissing crash is a valuable option for complex left main bifurcation according to definition 2 and DK crash 5 study criteria. And this is very important recent network meta-analysis which showed superiority of DK crash. I think it's very important to understand that there was no always direct comparison between provisional and DK crash. There was comparison between all the techniques based on the network principles. So if you do the most important sub-analysis and stratify lesions for the side branch to lesions shorter than 10 millimeter, you see in the summary clinical event rate with DK crash compared to other techniques does not differ if you have short side branch lesion. When I said short, it means less than 10 millimeters. However, if side branch lesion length is more than 10, then you gain advantage of using KISS, but this of using DK crash. But this we already commented on several occasions during this webinar. For diffuse disease, two stents are better than single stent. Here is the algorithm. It's based on the expected risk of losing the side branch after main vessel. So if the risk of losing the side branch is low, In that case, we recommend provisional, and after that, T, tap, or culotte. However, if we have major concern regarding the side branch, losing the side branch after main branch stenting, for experienced operators, DK crush is good option, or as we discussed again many times, inverted provisional stenting in this case from the left main into the circ and then doing pot, distal wiring, main branch post dilatation, and then inverted culotte, inverted T, or inverted tap. So you can use any of the three options. If you perform procedure at the high standards, your result will be optimal. Clinical outcome of your patient should be optimal. Briefly about these techniques, to try again to help you understand T and tap step by step, I made again second part of the video animation. So it's the same. We do provisional T or provisional tap. We do the same as we do for provisional. Stenting of the main vessel, pot to optimize the result in the proximal part of the main vessel, distal recross, you see with the pullback, opening of the struts with kissing, and then we put second stent with minimal protrusion to cover, but then you have this small new metallic neocarina and you do kissing. And then you repeat pot, but very proximal in order not to damage protruding part of the stent. And here in blue is what we say tap stenting. With tap stenting, you have this metallic neocarina, which you need to have if you want to fully cover the lateral wall of bifurcation. Just small illustration. After pot, if you are able to cross the very distal strut, in that case, you will push this metal, scaffold the ostium of the side branch, so you will do T-stenting. However, if you cross proximal strut, then you will not scaffold the ostium of the side branch, so you need to pull back your stent from the side branch, which as a result has small metallic neocarina. So tap, metallic neocarina, T-stenting, no metallic neocarina. You can see it here in the steel frames, tap and T, but I also use this animation to show you in parallel side by side. Provisional T on the left, provisional tap on the right hand side. You see protrusion on the left, you don't see protrusion here on the right, you don't see protrusion on the left, and now fly through just to show you again what happens inside the stent. This is the main difference between T and tap. You see now with tap on the right side, you have this metallic neocarina. With T, you don't have metallic neocarina, and I think it's very important to remember these images. DK crush has 7 steps: side branch stenting, balloon crush, first kissing, main vessel stenting, second pot, final kissing, and the third pot at the end. Again, our animation, wire both branches, side branch predilatation, main branch predilatation, as our colleague was doing, stenting of the side branch, proximal optimization, and then crushing with smaller balloon and sequential crushing with bigger balloon. And then first kissing. After the first kissing, remove everything, stent the main vessel and do pot, very important. Before recrossing, do pot, separate high pressure inflation in both, and then kissing, and then final pot. And you can see again in this animation that we prepared small crushed segment from the side branch. In this case, we also have small metallic neocarina, but from the main vessel stent, not from the side branch stent. What I was discussing, role of sequential crush. Again, Visible Heart Lab, this is crushing of the stent in the side branch using the balloon 3.5, you will see now, which is actually balloon sized according to distal part of the main vessel. You see how much there is floating when you use small stent from the side branch which protrudes. Then first crush balloon 3.5 by 12, As you can see, balloon is sized according to distal. You cannot use bigger one because you will dissect. But look what you have after crushing with that kind of selection according to main vessel. You see that stent is almost not crushed completely. So you can again recross in true lumen, and then by inflating balloon, you don't have crush. If you use pot-sized balloon, look with bigger 4.0 balloon size according to proximal part of the main vessel, look the result with sequential crush. Here is what you get. So much better and more adequate crushing, which allows you to do much safer steps. And again, repeat crush again with the same balloon, just to make sure that we fully crush protruding metal from the side branch. And this is the result after adequately performed sequential crush. So key points for DK crush: short protrusion of the side branch, balloon crush, proximal rewire, alternative inflation of balloons, and first kiss. Stenting of the main vessel, proximal rewiring, again separate inflation, second kiss, and final pot. And final technique that we also saw excellent demonstration is culotte. In culotte, again, this is the main vessel, the side branch, predilatation in both directions, and then this is provisional culotte, stenting of the main vessel first. Again, stenting according to distal reference. Doing first pot, please do pot. You see how important is pot. After pot, cross distally, open the struts, and here you can do decay crush. Protrude enough, optimally expand enough that with pot you are touching the opposite wall. Recross after pot, separate high pressure balloon inflation, and then simultaneous inflation and final pot. Again, with animation of the fly through, you see minimal proximal overlap and then full coverage, nice coverage of the carina. So both culotte and decay crush very nicely cover the carina. And these are tips and tricks of culotte and decay crush versus decay culotte. Decay culotte is important because you have much better coverage of the ostium of the side branch, but I also put your attention to the article of Gabor Tot in Neurointervention that was already commented, and you will see the details of decay culotte. In left main, you have specific anatomical characteristics like T-shape, large caliber discrepancy, a lot of calcification in that area. Ostium is frequently involved, and as we saw, circumflex is never small, and we have trifurcation in 10%. So sometimes circumflex is difficult to evaluate, to wire, it's angulated takeoff that may impact the prognosis. So we have to do this procedure based on the evidence. What we have currently is decay crush 5, but not to waste time, I will just show you lesion length of the circuit. Decay crush 5 is 16 millimeters. And in definition 2, it's even worse, 20 millimeters. And of course that for 20 millimeter long lesion, 2 stents are better, we have no doubt. So far, there is European Bifurcation Club left main study comparing single versus dual stent strategy. We completed recruitment 1st of December 2019, and we are awaiting result at PCR next year. So we will see if also EBC study will show better result in the left main for 2 stents or for provisional. Very few words on the use of imaging. Some operators experienced, they have belief that experienced operator will develop IVUS-like eye, gaining the ability to achieve IVUS-like results. On the other opposite end, we have polarized camps. There is, I always do IVUS. However, if we look the most recent publication from British Cardiac Intervention Society, we use imaging in 50% of the left main procedures, so it's not always, definitely. And the supporting statements not to use imaging are I learn from the experience. I respect fractal geometry and Murray law, Finet. I do pot, final kissing balloon, repot. Imaging is unnecessary cost and unnecessary time, and my left main PCI outcomes are anyway good. However, we wrote with Gary Mintz, European Bifurcation Club consensus on use of IVUS for left main, and we believe it's very important, at least for the beginners to use IVUS imaging or OCT, because procedure is much safer and much better result is achieved. We respect very much Dr. De La Torre Hernandez because he recommended predefined criteria for IVUS optimization, and what is very relevant, if you achieve those criteria, IVUS guidance of left main stenting provides prognostic benefits with respect to angiography guidance alone, particularly if you achieve IVUS protocol results which are predefined. Of course, difference is mainly in the TLR rate, but it's very important that IVUS is helpful and IVUS should be routine, of course, in the cath labs where it's possible to use it. Calcified lesions, we learn a lot. We use OCT and we can predict stent under expansion based on OCT criteria if the arc of calcium is more than 180 degrees, if the thickness is more than 0.5, and if the length is more than 5 millimeters, that stent will not properly open and that lesion needs modification strategy to make sure that stent will be optimally open. There was already a lot of discussion on antithrombotic therapy after PCI of bifurcations. This is again joint project. The first author is Marco Zimarino, but we have participants, big names, including Angiolillo and many other, Roxana Mere, many other very important people all over the world. I invited all of them to work together and help Bifurcation Club present. So I will not go again in details. I ask you to go to Euro Intervention and read, but we take into account in this document tailored approach based on clinical presentation, based on stenting strategy, provisional versus two stents, whether imaging or not was used, and the patient bleeding risk. And this is the final algorithm, which is very similar to one by Professor Ghazzal from the American College of Cardiology. So I thank you very much, and I would like to conclude that provisional side branch stenting is recommended for majority of bifurcations, including left main, because it preserves my options. I can always add second stent if I need. In our view, stenting technique should depend on individual patient characteristics, anatomical, but also on the operator skill. Two stent strategies may be considered for important side branch with complex and extensive stenosis, according to definition 2 study criteria, if we have difficult side branch access or we expect high risk of compromise. However, currently, among two stent techniques, there is strong randomized evidence for double kissing crash, while EBC main results are awaited. I thank you very much, and I hope I will have possibility to see you maybe next year live in Beirut. Thank you very much for your attention.
Thank you very much. Wow.
That's it.
We would really thank you very much, because this was, I think, the most beautiful, concise, direct to the point, very interesting step-by-step presentation of bifurcation, different bifurcation PCI techniques. We've enjoyed it a lot. We are very proud and honored to have you with us. We've learned a lot. Thank you very much again. I would like to see if Dr. Ghazzal, before I close or conclude, has any comments, because definitely this is a presentation that we have to comment on it.
Yeah, this was a really tour de force style presentation, extremely comprehensive. Dr. Malek, just to finalize on two quick questions before we close. One of them from Dr. Ahmed Sarhal. What's the safety of jailed balloon technique to protect the large side branch during stenting of the main branch? Do you resort to?
You know, some people recommend it, but you know, there is article from Francesco Burzotta in Eurointervention again. They jailed balloon in 205 bifurcations and they inflated that balloon 2 times. So you jail 200 balloons to inflate 2 balloons. I think it's self-explainable.
Yeah, and you could, I mean, let's say we have a jail a wire and that side branch is completely closed and the patient is having severe chest pain. You could always try to, at that point, to slide a tiny little 1.25 balloon under the strut and try to give it some wind until you rewire. So that would be, yeah. So I'm sorry we didn't answer all your questions, but I think we answered 95% of your questions. Again, Dr. Goran, we're so privileged to have you. It's been really, it's been really a wonderful webinar in your presence and in the presence of the participants. Personally, I would like to thank also the Lebanese Society of Cardiology, led by our president, Dr. Malek Mohammad, and the very good organizing team, and also of the Lebanese Society of Cardiology, and of course thank Medtronic for their support for this webinar. And the last word is yours, Matt.
I don't have anything to add on you, Ziad. Thank you very much, because this was a wonderful session, 2-hour session today, especially having Professor Goran, having you, Ziad. I think you made our life easier concerning the IVUS, the OCT. We hope the best for our colleagues to be more experienced and depend on their eyes because of our economic disasters. We don't have the opportunity to have IVUS or OCTs in all the labs because of the reimbursement. Thanks for this issue and for the upcoming ongoing trial that you have. We are eager to see the results. I would like to finalize and conclude by thanking you and we will see you next week with another session on CTO. I hope it will be as good as this session. I hope you stay safe, healthy in this pandemic to all of you.